We wrap up Disc 1 with a discussion Freek Verheugt had with Mark Ledwidge, a PharmD from Dublin, Ireland, and Dr. Kenneth MacDonald, a cardiologist at the St. Vincent's Hospital in Dublin, Ireland, on the St. Vincent's Screening to Prevent Heart Failure study, impact of natriuretic peptide-guided screening and treatment on long-term prevalence of left ventricular dysfunction, heart failure, and cardiovascular events.
Mark, can you tell me the rationale and the design of the study?
Prevention of heart failure is important. In some ways, it's a holy grail of cardiovascular care. And I think that many people would acknowledge that present approaches in that regard have been suboptimal. And biomarker risk stratification on top of conventional risk stratification may actually help. And in that regard, in 2004, data from the Framingham cohort showed quite conclusively that natriuretic peptide can independently predict the future development of heart failure in patients. And in fact, it also helps to predict the future development of other cardiovascular events. And so furthermore, in chronic disease, management structure is maybe just as important as the therapies that we use and the investigations that we use. So in 2005, we designed what we believe is the first large prospective, randomized, controlled study of natriuretic peptide-guided screening and collaborative care of patients at risk of heart failure, but not with heart failure. And the objective was to show a reduction after a long term of follow-up in heart failure and left ventricular dysfunction.
And how did the randomization go? What did you do?
So we linked in with a total of 39 primary care practices, and we were the single referral center for the investigations. And within these primary care practices, on an annual basis, the cohort of patients was initially screened and then randomized and then followed up annually. And annually, there was cardiovascular risk assessment done in all patients, including BNP. Now, in the group that was randomized to control, they received usual care, and the BNP was blinded to the patient and to the physician. In the intervention group, the patients and the physician received NP-guided cardiovascular risk factor advice. The risk assessment was repeated on an annual basis, so the risk assessment was constantly being re-evaluated as time goes on, as would happen in clinical practice. And if any patient at any point during the follow-up hit a BNP threshold of 50 picograms per mil, they were then referred in to the referral center for first echocardiography, further investigations as required, a specialist review by the cardiologist, and then collaborative care for the remainder of the trial.
Okay. And what was the outcome, Ken, of the study?
The primary endpoint was presence of heart failure or significant left ventricular dysfunction after a mean follow-up period of 4.2 years. The central secondary endpoint was the development of cardiovascular events requiring hospitalization. As I mentioned, the primary endpoint was heart failure and ventricular dysfunction. We defined ventricular dysfunction as an ejection fraction less than 50% for systolic dysfunction. And for diastolic dysfunction, we defined it as an E prime of greater than 15. In the control group, the primary endpoint involved 8% of the patients, or 59 of the total population that were in the study. This was reduced by the intervention that Mark has described by 37%, bringing the prevalence of the endpoint down to slightly in excess of 5%. The intervention affected all three components of the primary endpoint, the incidence of new onset heart failure, as well as the prevalence of both systolic and diastolic dysfunction.
In how many patients was the study performed? I forgot to ask you.
The study was performed in 1,378 patients from a screened population of 3,000. So the primary endpoint was achieved by the intervention, and the impact on the primary endpoint was predominantly in the group that had a natriuretic peptide greater than 50, and that's what we would have anticipated seeing. We also had a positive impact on the secondary endpoint, where the time to first cardiovascular hospitalization was delayed in the intervention group, as well as the absolute rate of cardiovascular hospitalization was less in the intervention group. Now, as Mark pointed out, the intervention is a disease management structure, and therefore it's a multidimensional intervention. And the question would obviously arise as to what brought about the impact on the primary endpoint and on the secondary endpoint. And again, I think this is likely multifactorial. However, we do get some insight from some changes that occurred during the study period as to what the mechanism could be. For example, there was a significant increase in RAS modifying therapy in the intervention group, with an increase in therapy of 14% in the population compared to 8% in the intervention group. And interestingly, this occurred without any change in blood pressure. So it appears to be a non-blood pressure mediated effect of the RAS modifying therapy. And the other central observation to mechanism was that we saw no difference in lipid lowering therapy between the two groups at baseline or during the intervention. But nonetheless, we did see a lowering of LDL in the intervention group. And this might suggest that the highlighting of risk to the patient resulted in better adherence or compliance. So a very satisfactory result from the point of view of the secondary endpoint. Mechanisms are probably multifactorial. And I suppose the final point I'd like to bring out regarding the results is the impact on natriuretic peptide itself. Natriuretic peptide continued to climb in the control group, but that degree of climb was attenuated but not statistically significantly in the intervention group.
What happened to the individuals in the open group that had a normal BNP at the start of the study?
That's a very important point. As Mark pointed out, the design of the study allowed us to continually reassess risk. So a baseline BNP would have been rechecked at year 1 and year 2, etc. And about 70 to 80 patients in the population changed from an initially normal BNP to an elevated BNP, and they would have moved into the cardiology intervention group. But in terms of the secondary endpoint in particular, we still saw a positive impact in the group that were in the open label but never developed a BNP greater than 50, which would suggest that maybe there was an alteration in primary care physician behavior based on their knowledge of the BNP, albeit not an elevated BNP.
That is very interesting. And now how can we go forward with these results? Is it getting into the guidelines in Ireland that the GPs should screen for BNP in high-risk individuals?
I think as Mark introduced it, it's a first step in a natriuretic peptide guided screening and intervention. We need to look at a lot more information that we have within the STOP-HF database to look and see whether we're taking the right cutoffs for natriuretic peptide, whether there's any way we can even further refine the risk. We need to look at the cost effectiveness of this approach, which we haven't discussed. We haven't analysed those data yet, and that's clearly a critical thing. But from the point of view of what's happening in Ireland, the Irish government are now taking this forward and rolling out a further pilot area, but not as a research project, as a clinical service delivery. So we're beginning to see this project take root as a clinical service in Ireland, but I think it requires a little bit more supportive data before it becomes an international guideline, I would think.
Mark, you're not afraid that you are going to medicalize individuals who feel healthy but do have risk factors with the yearly BNP screening?
I think that's an excellent point, but I suppose that the context that we've put this study in is on top of an at-risk group. So in fact, most of the patients that have been included and brought into the population are already at high cardiovascular risk. And I think that we have a considerable amount of annual data on BNP in a very large population. And one of the things that we're interested to see is in those lower risk or lower BNP subsets, but not quite normal. Perhaps they don't need to be followed up as frequently as we did in our study. So perhaps instead of yearly follow-up, we might look at 2 or 3 yearly follow-up. And these data, again, will be very, very informative and very important. I think that in addition, we need to continue to follow up this cohort, and we have the permission to do that. And also, we have been fortunate enough over the study to be funded to biobank samples from our patient cohort. And I think that that will allow us to evaluate other biomarkers retrospectively in the cohort, but still in a meaningful way, because perhaps BNP is adding value, but it may not be the perfect biomarker. There may be other biomarkers, and I think that those data will be very interesting.
Ken, you did see a difference in mortality because this is a disease with a high mortality in the future.
No, we did not see a difference in mortality. There were marginally more deaths in the control group than in the intervention group, but this would have no statistical meaning. The study was not powered to address mortality.
If you follow up them
Absolutely.
for 10 years, given the results you have now.
I think that's very important to do that, because I think the longer you follow this patient population, the more likely you have a chance of seeing a mortality benefit.
Mark, Ken, thank you for the interview. Congratulations with your beautiful study, which will be published, I hope, very soon.
Thank you very much, Rick.
And that concludes Disc 1 of ACCEL. For details about studies discussed, refer to the written summary that's included as a PDF file on Disc 3. Disc 2 begins with a discussion on aortic disease, Marfan syndrome, and coarctation.